having been associated with ma'am with several Foxy events and programs. It was a great experience, and of course, I'm looking forward to great learning opportunities with ma'am as well. Ma'am is the managing director of Sukhartha Hospital, Maternity and Surgical Nursing Home and Laparoscopic Fertility Center. She has got a vast clinical experience of more than 32 years. She has had a former 5 years teaching experience in SVN Government Medical College, and she has got the huge list of awards to her credit. She has been a
Okay.
national fact.
Okay,
Yeah,
Sushma, should
yeah,
suffice. Thank you so
yes,
much.
and and she's always been strongly associated with Foxy, the former chairpersons for the breast committee, government counseling member for the ICOG, and chairperson of medical disorder committee, and founder president of ISORAB in 2017 to 19, and president of YOGS in 2007 to 18. And Madam has rendered more than 300 lectures in national and international platforms,
Thank you,
and she
Sushma.
is,
I would request
yeah,
you to just hand over to me. Thank you so
yeah,
much.
ma'am. Thank you so much, ma'am. It's a pleasure to be with you all.
Yeah, thank you so much for that kind introduction. A very good evening to one and all. My respects and regards to all the seniors present here. The chief guest for today's program, Dr. M.G. Hiramat, sir is busy in another webinar, so he will not be joining today. Our Amogs president, Dr. Kiran Kurtakoti, and Dr. Durgada Sasrana, the president of Ksoga. I would like to also welcome the president and secretary of the Belgavi, Ballari, Davangere, Hubli Dharwad, Mysore and Manda societies. I would like to welcome the guest of honor, Dr. Kasturi Donimat, the past president of Ksoga, Dr. Vidya Thobi, also the past president of Ksoga, and Dr. Shobha Godi, the secretary of Ksoga. I would like to welcome all the speakers, especially Dr. M.B. Pilat sir and Madam Jaideep Malhotra will be joining soon. All the chairpersons and the esteemed panelists, I would like to welcome all of you and all the attendees who have gathered in a large number here. So without much ado, we would like to go ahead with the words of wisdom from our chief guest today. So I would like to invite Dr. Kiran Kurtakoti, Amogs president, and request him to share his words of wisdom. Yeah. All of you know that he was a Foxy chairperson for MTP committee and a very generous president and very gentle human being. So we would like to listen to you, Dr. Kiran. Yeah.
It's okay. Yeah. At the outset, a warm welcome on behalf of Amogs to all of you. And Sneha, first of all, heartiest congratulations, because on behalf of the Emergency OBGY Committee of Amogs, you have been doing phenomenal work. I think this will be your 500th webinar probably under this committee or chairpersonship. So thank you so much for that. I see lot of friends. I mean, when it comes to Ksoga, I feel like coming home, because see a lot of friends, Dr. Durgadas, of course, Mrutyunjay, and of course all the three guests of honors, Vidya, Kasturi, Shobha, and everyone. And I really look forward to meeting you all in person sometime. Dr. Meghaji, your name is revered with a lot of respect and dignity when it comes to fetal medicine, because when I talk to anybody about fetal medicine, whom should I invite from Ksoga, then yours is the first name that pops up. So really, this is the first time probably I'm meeting you. Yeah. So thank you, and of course Ram Raju. Hi, hello from
thank you.
myself to all of you. First of all, hearty congratulations to RCB. I mean, RCB is indirectly Ksoga. So heartiest congratulations for the IPL win, because you really snatched it away from Mumbai Indians, that is Maharashtra. But anyway, cup is yours. Okay.
Thank you.
So well, today's topics are really fantastic, and my best wishes, Neha, and everyone who is contesting whatever elections that they are. I know many people from Ksoga are also into elections. So best wishes to all of you, and I really look forward to all today's talks, and hope, wish and pray to see you all in the Foxy Presidential Conference, which we are going to hold on in the month of November, which will be Sunita Kandurwadkar's conference. Just remember the dates: 14, 15, 16, 14 November. Just remember Children's Day. On Children's Day, you have to be in Pune and celebrate like children in Pune. So welcome to all of you. And of course, in Amogs programs also, we are going to have two zonal conferences. So one will be in Solapur. I think Solapur is quite close to Karnataka. So I'll involve a lot of people from Ksoga in that conference. So please be there in large numbers at the zonal conference also. So thank you so much. Thank you. And please be with Amogs whenever time, energy, and physics permit. Thank you so much.
Thank you, sir. Thank you so much.
Thank you so much. So now we would like to go ahead with the words of wisdom from President Ksoga, Dr. Durgadas Asthana. This is your home ground and everybody is familiar with Dr. Durgadas Asthana. So without much ado, we would like to have your precious words, sir. Over to you for your speech.
Good evening, everybody. At the outset, I thank Sneha for involving me today. I'm happy to see my friend Dr. Kiran Kurtikoti. I think it's the second or third time we are only because of Sneha. You are building the bridge between Ksoga and Amogs. Amogs has become so close to us. Even Kiran Kurtikoti or Rajan Singh Pardesi. So many are very close nowadays. And really we cherish that good moment, and as just now Dr. Kiran told, we are eager to look forward to you in person. Coming to today's webinar, the topic chosen is so apt, regarding the MMR as well as the environmental influence on the fetus, fetus and the mother. We talked so many things about PA, diabetes, or so many other things. Whereas the least importance is given to the environment, which is the need of the hour. Starting from maybe take about the plastics or the pesticides, what we eat in our daily food, everything. The environment plays a very large role. And Sneha, you have taken a very up topic. And today's speaker, one of the great teacher, my friend Dr. Bellat, Dr. Jaideep Malhotra, and all the panelists, my close friends of Ksoga as well as Amogs. Really, you have chosen the very beautiful team, and everybody, the friends, the Mega and my dear Kasturi, everybody is so close to us, and this is only because of Sneha. Before closing my words, all the best, Sneha. We are always with you, and we look forward to come out with flying colors. Best of luck. Thank you.
Thank you so much. Thank you so much once again. And I know even I feel like home, always being with Ksoga. So thank you so much. I'm trying to bridge the gap between, I would say, all the states. So I'm happy for that. With this, we move ahead and have precious words from our dear friend, Dr. Kasturi Donimat. Everybody is so close to you, Kasturi, so that you really don't need any introduction. Such a humble and gentle human being. We would like to listen to you.
First of all, ellarigu namaskara. It's I feel very nice to be a part of this webinar moderated by Dr. Sneha. And Sneha is so close to me. She's like a very good friend. And I feel she's not part of Amog, she's part of Ksoga. She's like a family member of Ksoga. So we are very happy that you are conducting this webinar with association with all the 5 important societies of Ksoga, Hubli, Dharwad, Belgaum, then Ballari, Davangere, Mysore, Mandya. So we are looking forward to have a session with you, and then you as Dr. Durgadas said, you are connecting a direct bridge between Amogs and Ksoga. So many programs, and as Dr. Kiran Kurtikoti sir told, you have done so much work, so many programs as a chairperson of that committee. Amazing work, really amazing work. Your dedication, your hard work is really commendable, really. And very happy to see Dr. Kiran Kurti sir and Dr. Rajan Singh Pardesi. So we really feel close to Maharashtra Amogs, and definitely will attend presidential conference in the month of November. As you told, Children's Day, now it's gone in our head, November 14th. So we'll be there, sir, for the program. And very happy to see all the great speakers, Dr. Sneha, Dr. Bellat, Dr. Jaideep Malhotra, everything. And all the topics chosen are also very apt and very good. So and very happy to see our president, very dynamic president. Under his leadership, Dr. Durgadas, we have lots of programs, very something different programs, So we're looking forward for a much very successful year under your leadership. And Dr. Megha, as usual, very active member, very active in fetal medicine. As they told, any fetal medicine means we remember
Thank you
Megha.
so much.
Okay.
Thank you so much.
And Sneha, Sushma, and so many, all the presidents and secretaries of all the societies. So very happy to be a part of this webinar, and request you all to support Dr. Sneha, very active and very dedicated person for the post of VP. Thank you. Thank you, everyone.
Thank you. Thank you so
Neha,
much,
ma'am.
Sari. Yes.
Shobha ma'am is joining. Shobha Gudi ma'am is joining.
Joined or joining?
Joining, just 2 minutes.
So our dear friend Dr. Vidya Thobi is busy and she's not able to join today, though she's always there anytime. But we would like to have Dr. Shobha's precious words as Ksoga secretary. So I think just a moment, we have to wait for her to join.
So, ma'am, till then we can have a ceremonial inauguration of our today's ceremony.
Yeah, so
Yes.
you have left the inauguration. Okay, so lamp
Yeah.
lighting.
Yes.
So
I
let us
request
have
Dr.
God's blessings first, Stalin.
Yes, ma'am. I will go. Yes. Just give me 1 minute.
Yeah, ma'am.
Should I play, ma'am?
Yeah, I request Dr. Megha to invite everyone to lamp lighting.
Please go.
Thank you, Stalin. Ma'am, can we go ahead for the session?
Yeah, with the blessings of God Almighty and the blessings of respected seniors, we would like to go ahead with the academic session. If at all Dr. Shobha joins, we can have her words later. And we thank all the dignitaries, the chief guests and guests of honor, and all the president and secretaries to grace this occasion and get associated with Amogs for this academic session. Thank you so much, everybody. Over to you, Dr. Megha and team. We can go ahead with the academic session.
Yeah. With this brief introduction, we shall start the sessions. For the first session, I request Dr. Ramraju to take over the session, that is strategies to reduce MMR. Over to you, sir.
Yeah, it's my pleasure to. So I have to introduce chairpersons, no?
Yes, please go ahead.
Okay. The slide. Yeah. It's my pleasure to introduce the chairpersons for the first session of today, Dr. Ashalata Malapuri, madam. She is a professor and head of the Department of OBG, SN Medical College, Bagalkote. She has a vast experience of 3 decades in obstetrics and gynecology. She is
Ramaraju sir, thank you so much. Enough.
Experience in academic as well as research, and she has various webinar. Hello.
Thank you, sir. Thank you very much.
Yeah.
Thank you.
I warmly welcome.
Next chairperson.
Ma'am, Shobha Gudi ma'am has joined.
think we can just invite Shobha for her.
Yeah, Shobha, good ma'am.
Hello.
Ma'am, please start your video, ma'am.
Yeah, I will start.
Yeah, please. Good evening.
Yeah,
Welcome,
yeah.
dear
Good
Shobha.
evening.
We are waiting
Hi,
for you.
hi, hi. Yes, yes, yes. We are actually a
evening.
little busy with all the
I know that's
workshop
not good.
arrangements, all the workshop arrangements. So became a little difficult, but any time that Sneha invites or Megha invites, we have to honor that, and especially if it is a Mogs. It's a Mogs event, and with Dr. Kiran Kurtukoti being there and our champions of Ksoga being there, Dr. Bellet, and I can see a lot of friends there. Thank you very much for having me here. Fine tuning our skills in emergency obstetrics is the need of the hour. And the past 6 months have shown a slight rise in the maternal mortality. Sorry to say that, but it has not yet registered with all, but it has happened. And very rightly, Sneha has brought forward this kind of compendium of lectures of experts to deliberate on this subject. So I really congratulate the team, and I wish you all the best, Sneha, and all the speakers for today. I'm very happy that topics like this are being discussed. I think a lot of CMEs like this will go a long way in initiating interest in the management of high risk obstetrics. Thank you so very much. Thank you.
Thank you, dear.
Thank
Thank
you,
you so
Shobha.
much,
Thank you,
especially for joining from such a busy schedule. I'm sure your conference is just waiting for you to start. So all the best to your conference as well. So tomorrow, I'll be reaching tomorrow evening.
Yes, you're welcome. You're welcome. Yeah.
Shobha, I'm missing your conference because we
Yeah,
have a
we are
new
missing you.
neocon.
Yes,
Neocon
yes.
is there in Belgium.
Correct.
So that is
We
why
are
it's
missing
an
you. We are
important,
missing you.
yeah, one more
I
topic I
know
am
that.
addressing on birth asphyxia prevention. That is what my
You
talk is
told me.
asked.
Correct.
Thank you.
You
Yeah.
told me. Thank
So
you very
thank
much.
you so much. Thank you. And let us go ahead with the academic session. We eagerly waiting for you, sir, Dr. Bella.
I think Mamta needs to be introduced.
Yeah.
Sir, it's okay, sir. We know you and you know us. I think let us not waste time in that. I know most of them over here, and
Yes.
we have all the dignitaries. Please, sir, I think we'll start with the session.
Yeah.
Yes.
Stalin, you can stop sharing. I think.
I know. I think most of them know me, madam.
Yes,
You
sir.
can be very brief on that, is if at all you want to. Otherwise, no need for introduction also.
There are many youngsters, sir. So let them have your new introduction.
Yes, Megha,
So we would like to
please
highlight
do
your.
the honor. Yeah, let the person introduce sir first. Go ahead.
I request now chairpersons to introduce Dr. Bellet, sir, please. Aparna, you can take up.
Dr. Ballard sir is a very known familiar with everybody here as a professor, Department of OBGYN, KLE, JNM Belgavi, is the Dean KCOG, recipient of many national and international awards, and Ksoga oration at second Ksoga conference, April 2018. Sir, shall we sir?
No, I don't want you to elaborate too much on that, please. I
Yes,
have
sir.
more.
We know
That
you
is.
very well, sir. Thank you.
Yeah. This is a old one which is there now. I didn't share with her the latest biodata. It's okay. It's fine with me. Sneha, thank you for involving me. Somebody, please allow me to share my screen.
Yes, Stalin, please make sir the co-host.
Yes, ma'am. Yes, ma'am. Yes, sir. My voice is clear, sir?
Sir,
Yes, sir.
absolutely, sir.
Yes, sir.
Very clear, sir.
Yeah, my slides are seen.
No, not yet, sir.
No, please ask him to share with me. Allow me to share.
I have allowed you to share, sir. You can share.
It is not showing me that.
Yeah, the share screen icon green color at the bottom.
I know, madam. I have ticked that.
Yeah.
So Are you able to see now?
No,
Not yet, sir. Not yet.
Sir.
1 second.
Stalin,
Yeah, can you see?
Yes, yes.
Yes,
It
sir.
is.
Can you make
Is
it
it?
a slideshow?
Yeah.
Yes.
Are you able to see now full screen, right?
Yes,
Yes.
yes, sir. Very much, sir. Very much.
Yeah. Good evening. At the outset, I thank the Amogs and the Ksoga and the Dr. Sneha, Buyavar, and all my colleagues, Dr. Kiran Kurtkoti, Dr. Durgadas, Shobha Gudi, all Dr. EC members, Rama Raju, Asha Lata Madam, Mamta Madam. If anyone's name I have not taken, it's just to avoid the time. Thank you, everyone, and good evening, Kasturi Madam. So it's proud privilege to be associated in this. This is, I think, I am giving you the second time, I think, or third time, I don't know on this. See, reduction of maternal mortality is a really challenge now. You all know that. First of all, I bring greetings from my esteemed institution to all of you. And you know why this topic? You know what has happened? The scenarios, expectations, type of cases have changed. We need to address on preconceptional care, premarital counseling even at times, risk assessment at history, examination and investigations, counseling, which is very important. I request all the members who are attending this to adopt soft skills, 12 soft skills, if you want to grow professionally. And these are the major killers, that is anemia, preeclampsia, PPH, and the major killer of the baby is preterm births. And amongst the others, we have important cause like, peripartum cardiomyopathy and the jaundice. And what's the role of ultrasound? Specifically, I have mentioned that. So I have nothing to disclose. So you have seen now current Indian maternal mortality rate recently came up in the 6th of May. We got to know that our Karnataka maternal mortality is 63. Maharashtra is lower than us, and it has become, I think, if I'm not mistaken, second in the state. Tamil Nadu, it has overtaken the Tamil Nadu. And all India, we have maternal mortality now is 93. And this is a very important achievement for all the healthcare providers, especially related to pregnancy, childbirth, and postpartum or puerperium. So, that currently around 22,000 women still they are dying. But fortunately, now this has become so less, and CS cervix is killing more than what we are having the maternal mortality. See, look at the Kerala, which has achieved less than the USA. And then, they are earlier poorly performing states now slowly converging towards the rich, we are lesser maternal mortality. And see, this is what is the achievement. We have reduced tremendously from 556 in 1990 to 93 in 2025. That is the data of 2019 to 21. So thanks to everyone who are involved. Few states have already reached the below sustainable developmental goal, which we were supposed to achieve by 2030, but we should achieve this well before that. And what is important is what is the newer challenge is further reduction. Now, so far, they are very easily preventable causes. So this was 69, should have been 63. So these are the causes of death, still they are happening. And though Karnataka is less than the SDG goal, is there anyone wants to ask, please? Institutional deliveries have gone up, and we have already reached less than SDG, but Karnataka is north of South India. So the lowest number of deaths are in Kerala, followed by Maharashtra. Highest now is taken over by Madhya Pradesh, and second is Assam. So please understand, we need to further reduce this. It is only the mortality is just a tip of iceberg. The near misses are more than that. For every one death, there is almost 12 to 18 maternal near miss cases we notice. So where are we? So scenarios in patients have changed. The diseases affecting have been changing now. You are seeing scar pregnancy was never heard of. Placenta accreta in the first 30 years of my career, hardly I had seen. And today in the last 4 or 5 years, we have operated more than 50 plus cases. GDM, age-related changes, assisted reproductive techniques, post-surgical like cardiac and post-transplant pregnancies we are coming across. Knowledge and information is at tip of finger for patients, and information skills is added enormously every day. Difficult to cope up. Very high expectations from patients, community, government, and our own peers. Small and single child norm approach has become a practice that puts a lot of pressure on both couple as well as on the treating doctor. So case scenarios have changed, like age has gone up, parity is low parity, but some situations it is a high gravidity rather than parity. Expectations have increased. Associated conditions I just now mentioned, but obesity is increased, hypertension, hypothyroidism, others. So disease manifestations have also changed today, and you are not, we were earlier hardly evaluating the platelets. Today's platelet is the second hematological disorder after anemia. So the new cases we are seeing is post-transplant, post-cardiac surgeries. So the tests are available, newer ones, predictive models are available, preventive models or preventive strategies. Different approaches are there, different vaccines have come up, and machines, especially ultrasound and other imaging modalities, are really in a very, it places us in a very high tool categories so that we should not miss anything. And these are the danger things like placenta accreta and scar pregnancies. So assisted reproductive technique pregnancies, advanced age they are conceiving, and ART pregnancy is really a risk factor, and time factor for nobody. There is a patience now, and litigation we are worried about, fear of pelvic floor injuries and cosmetic concerns from the woman, and maternal requests like do at this time, delivery should happen before this, all these are there. And peer pressure, especially your own colleague, if the baby gets admitted in NICU for just distress or birth asphyxia, why you couldn't do it section earlier, what, or something like that, the questions will be raised. So greater change is quality of training. The healthcare providers training has gone to really in many places very bad. The acquisition of the skills are very poor, and technology based in all areas, including assisted deliveries. The technology is of help, especially ultrasound is being used on the intrapartum ultrasound. In utero treatments are coming up in a big way, and communication soft skills are very essential. And most importantly, if you have these two C's, communication skill and counseling skills, no one will go against you to any court or for the litigation. So these are the major killers. In some areas now, hemorrhage has been taken over by the hypertension now. So please understand, and the sepsis treatment delayed is treatment denied. And we are seeing also indirect causes are on the rise, like the jaundice and cardiomyopathy related, labor related still are happening. So how can we prevent these? We should have effective antenatal care, effective intranatal care, and postnatal care. I'm mainly stressing on the antenatal part because once you take care of the woman in a healthy situation, if she goes into labor, there, you can be almost reassured there. So delay in seeking care, delay in diagnosis, still they are happening, because recently I was with Dr. Rajkumar on the maternal mortality review, and I saw that many, cases, they came late on one side and they were managed inadequately and sent to the higher place in different places. So these are the major killers. We want to reach the neonatal mortality by 12 per 100,000, 12 per 1,000. Now it is 17 per 1,000 as per the World Bank data on 2023, and under 5 mortality is 28 per 1,000, which we should be able to reach SDG. So what is to achieve all this, it is important to have good antenatal care, which is a systemic supervision and care of a pregnant woman to ensure healthy baby to healthy mother at the end of the pregnancy. So this is what are the objectives of antenatal care. And one point I just want to bring to your notice, when you give antenatal care, please also tell and ask them to go and see where they have to come for emergency, because many a times they come in a daytime in a OPD, but labor rooms are situated somewhere in some other floor, and they will not be able to see if in the middle of the night or in emergency. So these all aspects, especially nowadays, travel related, clothing, sexuality, all these are, you must be able to explain to them. But one point I just want to highlight is this optimal state of the health at the beginning of the or entry of the pregnancy is very important for the good outcome of the pregnancy. So we should ensure that woman enters the pregnancy. For a war and all, we prepare and go, but unfortunately, most of the pregnancies in our women are unplanned. So we should see that she is healthy. So this is the important factor, and how we can ensure that her optimal state of health is achieved before entries, preconceptional care and counseling. So this is what the definition is about the preconceptional care and counseling. And objective is to ensure woman enters pregnancy with an optimal state of health, safe both to herself and to her fetus. So it helps that if the woman has a medical complications, it can be corrected, or the unsafe drugs can be changed to safer drugs. If she is using alcohol or drug abuse, can be avoided. Inheritable genetic diseases can be screened and they can be advised accordingly. Couples with recurrent fetal loss are investigated and counseled, and accordingly they are told. Identification of high risk factors, health status, rubella and hepatitis immunization, folic acid supplementation, allay the fear of pregnancy, provides an opportunity to control and optimize these prevailing diseases like anemia, diabetes, hypertension, hypothyroidism, epilepsy, etc. And we should change. Recently, we had one patient, I told this earlier, that they were on ARBs for hypertension. The patient has to be terminated because they are contraindicated. So we should change to safer antihypertensives. So this is what is very, very important as far as the preconceptional care. So the early first visit will ensure that the pregnancy is diagnosed, whether it is intrauterine or outside. And before 26th day of the conception, folic acid should be given. And decision to continue pregnancy or also can be decided, and easier methods to terminate will be there. So risks based on the history, these are the risks you can note by age, socioeconomic status and all. And I'm just going through all this because this is a very simple thing. Previous history, it's very important to ask about PPH, preeclampsia, preterm labor, or if it is a first pregnancy, and what were about the previous pregnancy outcomes. Please also note the interval between the pregnancy. This important information prepares us, because previous history of preeclampsia, 60% chance of recurrence. PPH, it is known to cause again, and preterm labor, it increases the risk. So all these factors we should note, and whether she is known case of heart disease or following these diseases. And family history should be very important. We should ask about the diabetes, hypertension, and other congenital anomalies which can run in the family, and other related to nutrition and infectious diseases. So this is very important. Adequacy in the diet, because most of them are in our women are deficient in calories as well as proteins, and many labor workers they are deficient in calories. So proteins have to be high protein, high calorie, high fiber diet, and tobacco use, smoking, alcohol should be avoided as far as you convince them to see that their effects. So based on the examination, high BMI, low BMI, and their gait will help to note. So these are the other general physical examinations which it will be noting. Most importantly, mean arterial pressure and the weight at the time, and the booking systolic blood pressures. So these are very, very important. And now we don't advise just HB urine. We say that complete hemogram. I told you thrombocytopenia has come up, and hemoglobinopathies we recently found in ours is not an endemic area for hemoglobinopathies, yet we found 9% hemoglobinopathies. So please understand RH grouping, and other specific nowadays we should look for is echocardiography, because cardiomyopathy is coming in a big way. In Tamil Nadu, they are routinely doing after I think 3 times, as informed to me by one of the OBGYN there, but at least in 2nd trimester and 3rd trimester, and if there is a preeclampsia, we should look for echo, because cardiomyopathy can occur because diastolic dysfunction is increased with the preeclampsia. So genetic markers, and if there are anything related to like baby related, we do double marker or quadruple marker, or we NIPT at all. So this is the counseling, very important. Travel and place of delivery, where she should come. And this is very, very important. We should tell, and when they should come back again and see you. These informations need to be addressed in busy antenatal areas. And this is what we should tell about the labor pain. Primary may not know, and about danger signals, which I will just come little later, and importance of ANC and emergency contact numbers, where is the labor room, where to come, all these information and transport arrangement, all this must be done. So each contact, we should look for assessment of maternal well-being and fetal well-being, and what has happened to the risk status. Has it remained the same as a low risk, or it has become high risk? Sometimes the risk status changes because of the complications. These are the 6 danger signals, and if they are noted, they should go back even if they have come from the hospital. So ultrasonography, I told you, this has changed our practice only, and when to do, how to do, what all things to expect, and it is important. And Doppler prediction, which is helping us to note. And also sometimes you need to take the help of MRI, especially in placenta percreta or scar pregnancies. So this is very important. As far as the first one, for early pregnancy, at least 4 times we recommend. First one is the diagnosis of pregnancy, to ensure that it is intrauterine, it is not in the lower anterior, especially with previous LSCS, and at 12 weeks for NT, around 20 weeks, 28 weeks, and 36 weeks. So we need to look at these placenta and other aspects and vessels for the Doppler. And because we are seeing all these complications, so we should be careful. And this is a scar pregnancy. And this is the next one. We injected KCL ultrasound guided. These are the facilities available now, so that you can inject directly and the cardiac stops slowly. And this is the injection of methotrexate into the sac, so that you don't have to do anything. Because if you don't diagnose scar pregnancy, you attempt for MTP or DNC, you will be actually end up in losing the patient at times, or hysterectomy needs to be done because they bleed torrentially. So this was a case of the hemoperitoneum with the scar pregnancy, the picture I had shown you earlier. So, and this is the scar pregnancy video. I am showing this. I'll just run this, and you see that how it is. See, this is the scar area. We had to excise it. And this was patient had come with a shock in hemoperitoneum. Don't expect that. Sometimes even if the patient comes like, there was a bleeding, we sutured it like a lower segment cesarean, and then she conceived again, and she has come back now with a full term pregnancy. So this is the, for placenta accreta, we should be looking like for this. And these are the subplacental vascularity. In the last 2 weeks, I have done 2 placenta percreta cases. So both hysterectomies we had to do because they are entered into the bladder. Challenges to overcome is anemia. If you want to reduce really maternal mortality, we need to address these 4 areas and the other jaundice and PPCM. So in that connection, I told you why anemia is important. It's a global challenge, and it has increased, from NFHS 4 from 4 to 5, it has gone up. And this is the state of affairs in all over the country. And these are the effects of anemia. And see how anemia causes. This I have enumerated many times on this. And these are the how it causes blood flow. And the anemic clots are not very, they are very much susceptible fibrinolysis. And please understand that, the anemia prevents lamellar flow. So that is platelets normally go at the periphery, RBCs in the center, but this, doesn't happen when there is an anemia. And directly iron deficiency can cause uterine atony, because iron is required for even myometrial contraction. So pregnancy outcome can be preterm labor in anemia 2 times more common. LBW is 3 times more common, and there is a higher incidence of abruptio. And there is all along we were taught that anemia does not have any effect on the baby, but you understand there is a neurodevelopmental sequelae of fetal iron deficiency. What happens is baby may not be anemic, but the stores are deficient. Transfer of these, and during brain development, iron is required, and that is affecting. We are doing what is known as the reducing anemia in pregnancy due to iron deficiency trial. We are looking in MRI of the fetus at 34 to 36 weeks. We have done MRI of the 50 pregnant women, and we are looking at 4 months, 12 months, and 24 months difference between when we are treated with IV iron at second trimester versus oral iron. And we also see that this, if the woman is having iron sufficient condition, their baby's brain development will be so good. Whereas if she is iron deficient, you can see the neuronal fibers, how they are broken. So please understand, this is happening, right? The birth with anemia, infancy anemia, adolescent anemia, adult woman again anemic, and she becomes pregnant and again give rise to birth of an anemic baby. So if we want to break this, we should treat and prevent anemia earlier to pregnancy or early in pregnancy. This is the classification, the severity of anemia and the diagnosis of cause, and you can come to know by this. And this is how the spectrum. Please don't think that one is not anemic, she is not iron deficient. This is called as iron deficiency without anemia. Iron deficiency anemia is a severe spectrum in this. So think about this. I routinely evaluate all the markers, and the best marker is these. I will tell you about the soluble transferrin receptor, STFR. That is the one which differentiates anemia, and it will help more than that. Oral iron, these are the salts available, and there is a newer iron called as sucrosomial iron. But please also note why we should think of parental instead of oral, because the hepcidin levels, they are increased when you give more frequently iron. So we should not be giving iron every day. Either it should be given alternate day or twice a week at a single dose, because hepcidin levels increase once the iron levels are more. And in chronic infection and other condition, there is an increased hepcidin. That's why it prevents iron absorption. Why IV iron works is, IV iron immediately saturates circulating transferrin and erythroblasts. Circulating macrophage iron increases, overcoming the hepcidin blockage. So that is why it is out. And every iron is protected because the elemental iron oxide core is very unstable. It is stabilized with the carbohydrate. So that's why all parental irons are with the carbohydrate. Like iron dextran came initially, then iron sucrose, then iron polymaltose, and now we have ferric carboxymaltose as well as iron isomaltoside or ferric derisomaltose. So all these are with this, and these are the single dose IV iron preparations available. In India, we have the last two only, that is ferric carboxymaltose and ferric derisomaltose, otherwise called as iron isomaltoside, which we can give in a single dose. So this is what a conclusion about the anemia. Treat anemia before she becomes pregnant. Prevent anemia for prevention of anemia-related complications. And if we want our next generation to be smarter, I mean intelligent, their mother should not be anemic or iron deficient. Prevent anemia at every level. Let us make anemia-free India and achieve the SDG goals well before 2030. And the next important condition we should address is preeclampsia. Prevention is now to a large extent possible with aspirin, and even now we have submitted one of the study for pravastatin along with aspirin. Prediction, we have the tests, early detection, accurate diagnosis, risk prediction, and appropriate management. So mean arterial blood pressure, then the systolic and diastolic. If MAP is more than 90 in the second trimester, this is the patient who is likely to be preeclamptic. So preconceptionally, we can prevent anemia so that the placenta is well formed and her PLGF level will be very good, and you can start aspirin. After conception, we should assess for risk factors, start with aspirin, and also test for PLGF and PAPA. Watch for BP, MAP, that is mean arterial pressure, and uterine artery, PIs, etc. So we have these scores. We have is Society for Maternal Fetal Medicine or Justosis score and FOXY together. We have biophysical and biochemical parameters. These are the specific risk factors for preeclampsia. And these are the secondly specific risk factors for preeclampsia. So urinary tract infection, age 40 years, we should think of all these. South Asian is a high risk population, body mass index of more than 35. But please also note that these can happen without these. So PLGF estimation may be helpful in every suspected cases.
Very wrong way of
Hello.
Please mute yourself.
Recording of blood pressure is very important so that we can anticipate. This was done in the periphery, and this is anybody can dance like that. Anybody can record blood pressure with this device, which is available from the MicroLife. Pre-eclampsia and the HTN related accurate diagnosis is very important. Proper evaluation and investigations, because most of the time practitioners think that controlling hypertension is only the treatment. Please understand, it is a multi-system disorder. Inside it is progressing. So we should be approaching with a multi-system management, typical or atypical type of preeclampsias and biochemical markers. So these are the ones which are helpful now in the diagnosis and exclusion of preeclampsia. So please understand, timely delivery, balance between prematurity and disease status. Control of BP is not the only means. It is better to give a healthy baby in NICU rather delivering preterm rather than giving a sick baby like in after abruptio or fetal distress. Counsel when you are observing. Please understand, even if you admitted the patient in ward, if the woman is pre-eclamptic, you cannot assure that in front of you, or when you are sleeping for few hours, abruption can happen and that can kill the fetus. So, and eclampsia can occur even in a hospitalized patient. Magnesium sulfate prophylaxis as well as for treatment and neuroprotection is important. So postpartum hemorrhage, another important cause, and still the number one cause, predict, prepare and handle, that is called as pre-PH by PPH. Newer drugs and devices and skills are now been documented. Safe delivery practices. Don't deliver placenta previa cases in your nursing homes. It should be delivered in an institute where blood transfusion and multi-system people are available. Placenta accreta spectrum, please understand early ultrasonography and where to deliver must be planned well. And previous history of PPH, please also note. Sepsis, I already mentioned that treatment delayed is treatment denied. It is an important cause. It is preventable. Prophylactic antibiotics, modified early obstetric warning score in a patient who has delivered under monitoring post-operatively or post-delivery, it must be adopted. Early evaluation and treatment will help and prevent the sepsis at every stage. And the other causes like peripartum cardiomyopathy, echocardiography is one of the important things we should think about it, because see, we are looking now to reduce further mortality. We should not be restricting on what we were practicing about few years before. So jaundice, we have to think of these four causes: AFLP, acute fatty liver of pregnancy, cholestatic jaundice, hepatitis and HELP. See, AFLP, cholestatic, HELP, they need delivery. Except hepatitis, all other three conditions need delivery, but the hepatitis, you should not be delivering them. They worsen if the delivery or abortion happens in that time. So please understand, most dangerous is AFLP out of all this. Second is HELP, and very comparatively milder is cholestatic. So the preterm labor, we have iatrogenic causes which can be prevented by, by preeclampsia and anemia, and we should add the neuroprotection with magnesium sulfate. So I just want to conclude that to reduce further mortality and morbidity, we need to strengthen the antenatal care by providing proper preconceptional care. And Sneha madam, tomorrow you are going to get elected as a vice president. Ensure that there is an eligible couple survey by the government of India every PHC. If we take care of these, the eligible couple who are likely to conceive, more than 50% of these women conceive. If we prevent them anemia, they detect diabetes, hypothyroidism, and all other medical disorders prior to, and we improve her health status, probably we can prevent the maternal mortality as well as give the good pregnancy outcome. Prevention and treatment of anemia and other conditions before and early in pregnancy. Predict, prevent, early, identify and treat the preeclampsia, preterm labor and PPH. Use of special investigations, and in sepsis especially, C-reactive proteins and procalcitonin are of great help. If we just correct anemia and prevent preeclampsia, we can significantly we can reduce the maternal mortality as well as morbidity. Appropriate spacing so that good maternal and newborn and infant health is possible. So what is the challenge? The challenge is now to reduce further both MMR and maternal near miss, NMR and perinatal mortality and infant mortality. This can be overcome by the engage, educate, empower the woman with community awareness, disciplined, dedicated, devoted approach with concern, care and commitment with effective and respectful communication by the healthcare providers and by the team of providers, care providers, administrators, and the system that includes community, healthcare providers, and the government. And please understand, every time we need to update ourselves, otherwise we will be outdated. So with that, I conclude saying that I know that I can't solve all maternal health challenges in the world by myself. I need and want others to join me. This is a midwife who told this, Christy Turlington. Women are not dying because of a disease we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. So this was told by the Muhammad Fathallah in 1997, who was the president of FIGO. So thank you. I have exactly covered in 30 minutes, and if you have any questions, please ask me without anything. There were videos of this, but time does not permit, so I have not been able to include. So thank you so much.
Thank you. Thank you, Bella sir, for your wonderful talk on various strategies to reduce MMR. And now ask chairpersons to give their expert opinion on this talk, please.
Thank you, Bella sir. It was wonderful talk, truly inspiring and informative. And though it is so challenging, by listening to your talk, I think it is made easy. So you have covered preconceptional care, then timely care, communication skills, how to examine, when to take decision. Very nice, sir. Very nice. So on behalf of everyone, I extend heartfelt thanks to you, sir. Let's take these insights forward in our daily practices to prevent further maternal mortality. Thank you, sir.
Thank you.
Thank you, sir.
Thank you, madam. Thank you.
Very
Any
wonderful,
questions?
wonderful talk.
Yeah, so we welcome Madam Jaideep Malhotra, who has just joined, and we're eager to listen to you, Madam. I would also request you to make any comment about this topic, because this topic is also very close to your heart, I know. So you can make at least a comment on this, Madam.
Thank you so much, Sneha. I think Dr. Ballard, it was a wonderful presentation. And I think all of us just need to realize that we have to do much more than what we are actually doing. And every woman's life really counts. And it's not going to be done in a day or in a year. It needs a consolidated, passionate, and a lot of hard work which has to be put in. So I would say that first of all, it has to be, we have to be sensitive towards, and it's not only going to be us doctors, the families also have to be equally responsible if we have to save more women, and maternal mortality has to reduce. It's not, again, I talk a lot on this because I think the preparation starts from in utero. Because when a woman is, well endowed, has a better upbringing, and is empowered, educated with all kinds of the right, ingredients, that is when she goes into a family who really respects her presence and values her, then only we'll be able to save lives. We doctors are definitely doing whatever can be. And a very important aspect, which again I always say, is nobody can do it alone. So we must take help of our, friends, the support staff, and more so involve our nurses, midwives, and let it be a cumulative effort. It cannot be done alone. So thank you so much for a lot of insights. It was a wonderful talk.
Thank you, madam. That's why I tell team. Team is together, everyone achieves more. So it's a teamwork. Even though we project certain things that we have done, but it is behind that, there is a nurse is there. There is a Aya also is there. Our resident doctors are there, and patients and their relatives also contribute on this. So it's not an individual effort. It is a teamwork. and together everyone achieves more. That's why, madam, I congratulated all those involved in bringing down the maternal mortality. I used to wonder when joined in 1990 as a lecturer in OBGYN, 556, and I used to think of this developed world, they were so less. Today, I'm at least very significantly, I'm happy that I retiring with the maternal mortality, which has come down below 100. And really thankful to all the members, all OBGYNs and all the healthcare providers. Thank you.
Thank you, sir. Thank you so much.
Thank
That's excellent as always, and really thought-provoking for all of us as obstetrician as well. So hats off to you. And yes, the message very well delivered. Preconception, counseling, care, and evaluation, everything matters. And of course, the team. We would like to move ahead with the second talk by Madam Jaideep Malhotra. And I would like to request the coordinator to...
Sneha, 1 second. Sneha,
Yes.
shall I say something? I request everyone to please go through my opinion article, which has come in the Hindu on May 27th about prevention of anemia before the pregnancies. This has been published on 27th May. If you are if you don't have Hindu, I will share in WhatsApp. So please go through. It will be my pleasure to have that. Thank you.
Thank you, sir. We can go ahead with the next session. Yeah, Dr. Megha, we can go ahead.
Yeah, Dr. Raju? Dr. Ramaraju? Is there?
Yes, yes.
We can introduce the chairpersons in short and go ahead with the talk.
Yeah. For session 2, I request Dr. Sushma Dev to take over. The session is Environment and Women's Health. Madam, kindly introduce the chairpersons.
Good evening once again, and we'll move on with the next session. It's a privilege to invite the chairperson for the next sessions. We invite Dr. B.R. Bharkol, who is the professor and head of the Department of OBG, KLE JJM Medical College, Hubli. Sir has done his master's from Pune, and he served in the Indian Air Force for almost 24 years, and has worked in various capacities. In the past 4 years, 2 years, he's been the head of the department, and he's got a lot of experience in the OBGYN. We welcome you, sir. Thanks for accepting the invitations. And we have our own good friend, Dr. Anupama Sundar, Secretary of Ballari OBG Society. Welcome, Dr. Anupama. And the other chairperson, we welcome Dr. Sumaya Firdos Patel, who is a consultant practicing since 28 years in the medical, and she's the medical director of City Hospital, Belgaum, and the president of Belgaum OBGYN Society and joint secretary of Indian Menopausal Society. And we welcome Dr. Sumaya Firdos. Now I request the chairpersons to invite the speaker.
Yeah, can we have Madam Sivi? Yeah. I think. Yeah, Dr. Bharkol, please go ahead.
Good evening, everyone. Good evening, Dr. Jaideep Malhotra, madam. And everybody knows Dr. Jaideep Malhotra. She doesn't require any introduction, but still will cursory sake, we'll introduce her. She is member of Accountability Group, PMNCH, WHO, and she is also immediate past chair FIGO, REI committee, president-elect INSAB, past president Aspire, Foxy, ISAR, IMS, SAFOMAS, ISPA, editor-in-chief, SAFOMAS, journals and many books, co-editor of more than 65 books, regional director, South Asia, Ian Donald School of Ultrasound, Professor Dubrovnik International University, Croatia. She is professor of that. Past secretary and vice chairman, ICOG. With this small introduction, I invite you for your deliberation.
Thank you so much, and a very good evening to all of you. Thank you, Sneha, for this opportunity. And again, I'm going to really talk on something which is quite close to my heart, because this is something which I have been working on for a very long time, and also have been working in collaboration with the FIGO Committee on Environmental Health. I'm going to just limit my topic because it's a very huge topic, and I'd really like to wish each and every one of you. Yesterday was World Environmental Health Day, and I'm sure each one of us celebrated it in our own way. The theme of this World Environment Day was say no to plastic pollution. And that's something very, very important, which we have to understand. And I think it's not only the public, all of us in the medical fraternity also have a lot to contribute towards the environmental health. And it should give us a lot of insight into how all these things are really impacting our lives and our future generations. As we understand, the world is really changing. The trends in human diseases, I think in our own course of time, we have realized that trends in human diseases and environmental toxicants are basically, there all over the globe, which are mostly contributed to the endocrine disrupting chemicals and the air pollution, which is disrupting our reproductive health. There are lots of gaps in our research, education, and our health policies, which need to be addressed. Now, as we go further, we have to also understand if you see today, India is the obesity capital of the world, India is the diabetic capital of the world, India is also having a maximum cardiac episodes, which are coming almost like a decade earlier than the Western counterparts. Plus, we have maximum number of preterm births. And the important aspect is that when we talk about, like we had just had a talk on maternal mortality just before me, Dr. Bellard talked about. What we are now understanding is that the normal causes of maternal mortality, now NCDs are contributing much more because we've reduced the maternal mortality from all those causes, but NCDs are the ones which are contributing more, and NCDs are increasing globally. So as I said, we need to do much more. So we need to connect the dots here. Because this marked increase in NCDs, which is relevant to the reproductive health and its outcomes, which you understand, obesity, diabetes, neurodevelopmental disorders, respiratory dysfunction, thyroid dysfunction, cancers, declining age of puberty and menarche, and declining sperm counts, all of these are leading to a reproductive compromise. Now, as you see here in this graph, we were like about 3 billion in 1960. Now, by the end of 2050, we will cross 9 billion. This population explosion is just enormous. I don't think our Earth actually can handle. Now, what we see on this particular area here in this picture, now the countries, the top 30 countries with the greatest projected population increase and decrease between 2020 and 2100. And if you see here, these are the ones which are in the red and which are the ones which are decreasing, and the population is increasing in all this area, which is green. Luckily, India is there in one of the stable areas. But what is this population, or what are these human beings doing to our Earth? If you go through the COVID, now during this COVID period, what we understood was like more than 120 million hectares of the tree cover in the tropics was lost during the COVID period, or 2020 alone. And in a year when everything else had slowed down, the forest loss sped up. Similarly, when you look at the other areas, like if you see 73% of the households use unsafe water, 63% of the people face difficulty in even getting drinking water, 51% face water crisis, and basically all this is what is happening here. Even when we look at the Ganga, all the rivers all over are so much polluted, and it is not only affecting us human beings, it is affecting our whole ecosystem. Now, we are dumping plastics. Now, let us understand why we are focused in this year's theme on environmental health on the plastics, because I'll just give you a very small figure. 4 billion plastic microfibers per square kilometer clutter our seas. Between 4.8 to 12.7 million tons of plastic pieces are dumped into our oceans yearly. One big truck of plastic is being dumped into our oceans every minute. I mean, this is horrendous. Can you see this whale which was found lying on the seashore? Can you imagine what amount of plastics this whale has consumed? And this is just one picture. I can show you thousands of them. So this is basically disturbing the whole ecosystem. And what will happen? We have already run out of all the seafood, and we'll run out of it. Maximum collapse will happen by the 2050s. Even today, 40% of the seafood which we are eating basically is artificially produced. And 22% of the food which we eat today is adulterated. And this is not only in our country, it is globally. Humans are actually consuming 40,000 and breathing 74,000 microplastics every year. Now, this is unimaginable. And what is also unimaginable is that like even newborns are being born with these microplastic fibers inside them. And this is one of the most scariest part. Now, if you look at the cities today, this is how in the world our region stands. Lahore is one of the most polluted ones. In Delhi comes second, and Bangladesh comes third. Now, when I have told you about this particular scenario, all this pollution and the chemicals which are there, which are causing the pollution, are actually contaminating all of us, men and women. And all of us have a very measurable contaminant number in our body. Now, what do these chemicals actually do? Now, these chemicals, as I was telling you, they are present in the pregnant women. They are also, babies are born pre-polluted. And these chemicals are basically endocrine disruptors. And these endocrine disruptors actually interfere with every aspect of the hormone action, which actually happens in our body. And this has a lot of scope in changing the life course of each one of us. Now, a lot of them, how these endocrine disruptors actually act and how are we really exposed to it. So can you imagine we are consuming quite a few of them? We inhale a lot of them. Some of them we are absorbing through our skin. And a lot of this industrial pollution which is happening, basically the waters which we are drinking. Now, all that can have causes a lot of inflammation, oxidative stress, changes our microbiome, ultimately the metabolomics, the hormonal interactions, and ultimately leads to not only the changes in our own body, but our epigenetics has changed. So then the future generations are going to be affected by these pollutants and the endocrine disruptors. Now, these endocrine disruptors, quite a few of them actually resemble our endogenous hormones. So if you see here, this is the endogenous hormone receptor, and this is the endogenous hormone. Now, the EDC or the endocrine disrupting chemical is exactly of the similar configuration as the endogenous hormone. So it combines with the receptor and can then bring about all the changes which our endogenous hormones are supposed to bring, which could actually be in the form of proliferation, apoptosis, or differentiation. I'll just give you one small example of how proliferation is going to affect. So we have like bisphenol A, which mimics estrogen. Now, when we have exposure to bisphenol A and it combines with the receptors in our body, it is going to act exactly like estrogen. And once it binds with the receptors, and let's say these receptors are there in the breast, normal breast, bisphenol A is going to bring about proliferation and then lead to breast carcinoma. Now, this is just one small example. Now, we have to understand how detrimental all these environmental pollutants can be to our health, and they affect every stage of our lives. whether it's intrauterine, perinatal, puberty, adult life, or even in later life, they affect us throughout our life. Now, what are these? I'm just showing you small examples. The canned fruit, food liners, the plastic containers which we use every day, the plastic bottles in which we drink water every day, the epoxy adhesives which we are using, the toys with which our children are playing, the pipes which we are using, the packaging material, you name it, and it has at least one of the EDCs and will have an effect on our bodies. Now, there is a connection between all these. Now, when we look at the environmental contaminants, the plasticizers, the pesticides, which are used so much in our farming, the preservatives, which are used, for a lot of foods which we eat, or the cosmetics which we are using, the sanitizers which we are using, and plus the air pollution, all of them have either obesogenic, diabetogenic, thyroid disrupting, neurodevelopmental disrupting, or reproductive disruptors or fertility disrupting problems, which are just unimaginable and are very, very difficult to take care of. So EDCs, basically, let's see what we have studied in the past 20 years plus, can affect all of these functions of our body. I'm just telling you a little bit about the fertility or the reproductive functions. So whether it's ovarian function or, menstrual cyclicity, PCOS, endometriosis, time to pregnancy, pregnancy losses, or, pregnancy outcomes, all these can be affected by exposure to EDCs. Now let's talk a little bit about bisphenol A, which I was telling you, exposure. What happens when a mother is exposed to bisphenol A? It disrupts the early meiotic events in the fetal ovary. So the bisphenol A exposure basically increases the oocyte loss. The chromosomally abnormal eggs are there, and the embryos also, when they are formed from these eggs, are going to be aneuploidic. Now, what is shocking here is that this is transgenerational. So the mother who's exposed to bisphenol is affected. The fetus which is inside the mother's womb is affected, and the gametes of that fetus inside the mother's womb are also affected. So 3 generations are going to be affected, and this is transgenerational. Now, we have lots of other issues also, like the heavy metal exposure. I don't know how many of you know that the fish which we eat is actually loaded with mercury. So we really don't know what to eat. The other heavy metals which are there, which are being used all the time in our housing environments, the sanitizers, the cleaning agents, the toys, they're all sort of loaded with lead, mercury, cadmium, and arsenic. Now, lead, as we know, is used in paints. There are lead pipes from which our water flows. The cosmetics have lead, the construction sites and the herbal supplements, all of them have some amount of lead. But the moment this level goes beyond a certain point, which is about more than 15, it is associated with a twofold increase in the infertility risk. And also increased exposure to lead actually increases the risk of spontaneous abortion and preterm birth. Now you're looking at the various other reasons for an abortion happening, but nobody has ever thought it in this way, whether this lady, is she really exposed to a little more increased lead exposure, which also could be a reason for her spontaneous abortions or preterm birth. And that's something which I would definitely like all of you as a food for thought to understand and think over. Similarly, mercury. Now, as I said, the fish, especially which we are eating today, is primarily loaded with mercury. And mercury enters the seascape through the industrial waste, which we are dumping into our rivers, and the rivers are going into the oceans, and they are just sort of, contaminating the whole ecosystem as far, and the whole food chain and the whole water ecosystem which is there. And it really we have to understand that if the preconception period, elevated mercury levels are there, then definitely a lot of harm can actually be done. Cadmium is another element which, exposure basically is coming from rechargeable batteries, which we are using in our everyday practice. Certain paints and plastics have a lot of cadmium. Now, if it can enter the food supply through resorption from the soil, and basically, goes into the food, especially rice, wheat, leafy vegetables, and shellfish. Cadmium levels are also increased, seen in, cigarette smokers. Now, all these levels can also decrease oocyte fertilization and implantation rates, which are definitely going to have a very detrimental effect on our future progeny. Similarly, Wi-Fi exposure, all the cell phones and the towers which are there in our near vicinity and all can have a lot of effect on the sperm count, sperm motility, morphology, viability, and also on the oxidation patterns. Now, if you see here, all these EDCs which are there, they affect each and every step of oogenesis, which you can see here, right from the primordial to the primary, secondary, and the Graafian follicle, and also every step of steroidogenesis. So it is a huge role which they are playing in disrupting our day-to-day life, and these disruptions in oogenesis and also in steroidogenesis can actually play havoc with our reproduction and menstrual cyclicity and many other issues. What also has been seen that if women who are basically exposed to bisphenol A have a diminished ovarian reserve. Today, I can tell you that worldwide, if the premature ovarian insufficiency prevalence is about 1%, in our country, it is 3 to 5%. So we definitely need to check on what is going wrong. Why are our women having such, high degree of premature ovarian insufficiency? Similarly, if we are looking at these EDCs, they are having the effect on the uterus, vagina, and also on the hypothalamic pituitary ovarian axis, which again is very, very disrupting. Not only that, what has been seen that, boys who are born with cryptorchidism, their mothers have had high levels of bisphenol A. So this is only one EDC which I'm talking about. You can imagine there are thousands of them which are there, the PCBs, the organochlorine, the phthalates, which the DDT, the benzene hexachloride. Now, benzene again is something which leads to is in sunscreens, and most of the sunscreens we have benzene, and again it is something which can cause malignancies, which are very important for us to understand. So phthalates and organochlorines basically are consistently have an increased risk of abnormal sperm quality. So if we are looking at an environment as a whole, whether it's environmental exposures or lifestyle factors or epigenetic factors or genetic defects, all of them in men also can lead to testicular dysgenesis, which can again lead to a lot of decreased testosterone production and impaired germ cell differentiation, which will definitely lead to reduced male fecundity and reduced pregnancy rates. So I just come to a little bit on the ART. Now, when we are exposed to all these environmental toxicants, now if all these men and women are undergoing IVF, how are their outcomes going to be? So we have already understood that these environmental toxicants are going to have an effect on almost every possible step, starting from ovarian reserve to follicular dynamics to oocyte quality to embryo dynamics, fertilization, and the pregnancy outcomes. But what has been realized here is that people who are exposed
very little money what I had invested,
to
but now
people who are exposed to bisphenol A have decreased serum E2 levels. Similarly, ones who are having exposure to PCBs have decreased serum AMH levels. Similarly, low antral follicle count, poor oocyte quality, lower fertilization rates, lower implantation rates, poor embryo quality, and lower clinical pregnancy rates can all be attributable to a number of these EDCs or toxicants which are present in our products which we are using on a day-to-day basis. So I think it's high time that we understand this and we start reading all the labels and start moving towards a little more organic life than the inorganic life. Now, whenever somebody is pregnant or somebody is looking at fertility, they come and ask, "What should I eat, doctor?" And we say, "Oh, green leafy vegetables and lots of fruits and all." Can you imagine? This study was done just a few years back, and what did it tell us? That women who ate more of these pesticide harboring green vegetables and fruits actually had lesser success as in the fertility treatments. Now, can you imagine now where we reached? Similarly, another study said that people who are living in proximity to the major roads, again, the air quality in their houses is not as good because they are harboring a lot of nitric oxide, sulfur oxide, dioxide, and all those, which are coming from the diesel exhaust pumps and on the major roads. Again, in those couples also, the fertility outcomes are definitely much, much reduced. So is there really any hope? What can we really do? The first and the foremost thing which we have to understand is that we have to understand that our environment is totally polluted and we are the ones who are responsible for it. So we need to replace the hazardous chemicals, processes, and products with much safer alternatives. Are there any safer alternatives, which are again very, very important? Now, as I said, like the bisphenol A, we have had number of studies where bisphenol A was replaced by bisphenol S, and it was seen that, or bisphenol F, but it was seen that they were not really as safe as we were really wanting to. And all these plastics, which are really producing a lot of these endocrine disruptors, need to be replaced by better alternatives. And for those better alternatives to come, what is important here is that we need to educate our public well. We ourselves need to be educated. And this was just a survey which was done amongst obstetricians and gynecologists on how preconception counseling needs to be done. Because what is preconception counseling meaning to us today? All what we are doing is we might just tell them, to reduce their weight, take folic acid and thyroid supplements, and maybe that's all. But preconception counseling is a much, much larger topic, and it needs to cover up all these endocrine environmental exposures. Which are very, very important. And this education is also very important so that we obstetricians, who are the first contact, are able to educate a lot of couples and families on environmental health. Secondly, the professional organizations have to work closely. I know I have worked with FIGO, even Foxy is also doing, even in my tenure as a Foxy president, environmental health was one of the topics where we planted almost 1 lakh trees. We propagated, reuse, recycle, and prevention of plastics. We were paper free during that year, and we need to do much more. So all the organizations in the world have to get together and start taking and creating awareness against all this, which is very important for us. We also need to have policies to prevent exposure to toxic environmental chemicals. We need to work to ensure that a healthy food system is maintained for all of us, because a healthy food is one of the most powerful medicines which we have. Making environment health part of our healthcare system is again a very important aspect which all of us need to be very sensitive to. And we need to also champion the environmental justice, because dumping by the industries all the waste into the rivers and all needs to be curbed. We need to encourage people to eat more organic food. I would encourage all of you to grow all the green small herbs like dhania, mint, and all these small herbs in small potters where you can very easily grow, because these are the ones which harbor the maximum pesticides. And if you're able to do that, if you're able to wash your fruits and vegetables and our hands thoroughly, if you're able to minimize the plastic use in our homes, all the cling films which we use, all the microwavable utensils which we are using, second-hand smoking, all, if you're able to do that, minimum of cosmetic or personal care products, which, and also see that they are phthalate free. Avoid hand sanitizers and digital paper receipt handling, and try to grow some small pots with green plants and keep them in your bedrooms, because that is the air which you are going to breathe at least 12 hours in the day, and this would definitely lead to a lot better outcomes. Go for sustainable things, and especially replacing all plastics with glassware is very, very important. I have this glass of made of glass, which I have on my table every time. I carry my own steel bottle with water so that I don't have to drink water from those plastic bottles. These are very, very small steps which we can actually take to champion this big change which needs to be there. Now, I'll just give you, one example. Doctors in Scotland are prescribing nature to their patients. They're just telling them to go and, spend about 5-6 hours in a day in a place where there is much healthier oxygen environment, and take a stroll at least 4 times a week in that environment, which will probably add a little value to their or improvement to their health. Now, I don't know whether we can do that, whether we can find some places in our own country, but I think we can make our own resorts with planting some more trees. Neem tree is giving a lot of oxygen and it has a cooling effect of 3 air conditioners. We can do, plant some trees around. We can plant some small plants in our house, which will definitely improve the quality of life which we're going to lead. Now, lastly, I would still like to end at a positive note. Now, if you see these pictures, one of the pictures is from which is 20 years back, and the other picture is now 20 years later, which shows that, the greening effect of the earth basically has shown a lot of improvement as far as India and China are concerned. And if all the other countries also start, maintaining these small changes, I'm sure this world will be definitely a happier place to live. So let us protect our reproductive health now and for our generations to come. And we take those small steps, which are definitely going to bring in a lot of change in our future generations. Thank you so much for having me, and wish you all a very happy Environmental Health Day.
Thank you very much, ma'am, for a very enlightening talk. Indeed, madam has very rightly pointed out that these microplastics are also found in the placenta. It's been found, studies have shown. So how plastics are affecting 3 generations, not only 1 generation that we had thought earlier. So they're affecting fertility. The FDA has also now recognized molecules like exobiomes and enterobiomes, which affect the estrogen metabolism. And this is indeed alarming. And like madam rightly said, we need to find an alternative to plastics, and we need to urgently, albeit a bit late, strive for a plastic-free world. We need to teach our small children how to live in a plastic-free world and encourage a plastic-free environment. And again, she's rightly pointed out about the need for policy changes. And what I like very much, she spoke about environmental justice. This is a term, I think, which is very, very important and very powerful. I think, madam, your talk was really wonderful, and it was an eye-opener. And it's a lesson for all of us that we need to learn. We need to live a better world for our next generation when they come in, and they must come into a healthy environment. Thank you, madam, for your wonderful talk.
Thank you.
Good evening, everybody. Dr. Jaideep, that was a wonderful and an exhaustive topic and lecture, and you covered so many points. I think it is also a lesson for us gynecologists, obstetricians, to spend more time talking to our patients about all this. And as you said, just eating green leafy vegetables, instead of that, we can tell them that go organic, grow your own plants, and try to eat them as well. So that was really very excellent lecture, ma'am. Wonderful. Thank you.
Thank you. And I think also what is important, our hospital waste is also a big contributor. So we have to do a lot more as far as our hospital waste management is also concerned.
Thank you very much for your lucid talk, ma'am. In general, actually, spermatozoa count is going down in males and PCOS is increasing. It is all because of the environmental chemicals, and we are responsible for that. And we should wake up, and this is the wake-up call from you. Thank you. Thank you very much.
Thank you, madam. Thank you so much. That was really an eye-opener. And of course, endocrine disruptors, as you always stress, and not only you, but everybody should, nowadays believe on the Barker's hypothesis. It is the fetal origin of the adult disease. Definitely, all of us should take care of ourselves as well as our environment. So with this, thank you so much, madam. In spite of your busy schedule, you joined and delivered the best. Thank you so much.
Thank you so much, and all the best to you, Sneha.
Thank you, madam. Thank you so much.
Thank you. Thank you.
Yeah. Thank you. So we can go ahead with the next session, and over to you, Dr. Amaraju. And
thank you, Madam. Jaideep, Madam. I interpret this as be the change you want to see. So we'll definitely take that initiative. Let's go to the session 3, the most interesting part of the webinar, the panel discussion on fetal environment. I request Dr. Megha to take over the session. Over to you, Madam.
Yeah, can I have a series of Dr. Sudha R. Ma'am? Yeah, Sudha ma'am is a medical superintendent, Chaluvampa Hospital, Mysore. She is former HOD professor, unit of Department of OBG, MMC, Mysore. She has been the past president and secretary of Mysore Obstetrics Gynec Society. She was a chairperson for Menopause Committee, Ksoga, and she was organizing secretary for UFOXI National Conference in 2014. Apart from her exhaustive 22 years of teaching experience, she has been a master trainer for national health programs. Then she has a diploma in hospital administration from Sikkim University as an additional qualification. She has undergone basic and advanced histolaparoscopy training in Bangalore, and she has presented many lectures, orations in states and national conferences. She has organized many CMEs and conferences, and on her name there are a lot of publications, national and international journals. We welcome you, ma'am, Dr. Sudha.
Yeah, welcome, Dr. Sudha.
Thank you.
Welcome, Dr.
Thank you, ma'am. Thank you so much.
Can I see you, Dr. Shobha Dhananjay, ma'am? She is a professor and unit head Department of OBG, JJM Medical College, Davangere. She is chairperson of Prevention of Violence Against Women, BOC Committee of Ksoga, and she is the president of OBGY Society, Davangere, since 3 years. She has been a UG and PG teacher since last 25 years at JJMC, Davangere, and PG guide also since 20 years. She is an examiner for UG and postgraduate examinations, and she has presented many papers at state and national levels. And she is president of Inner Wheel Club, Rotary Club. I welcome you, Dr. Shobha. Can we request a chairperson? Yeah, and we have another chairperson, Dr. Manohar.
The panelist.
The panelist. It's a pleasure for me to welcome you, Dr. Manohar. He's a present secretary of Bagalkot OBGY Society, director of Bagalkot Multispeciality Hospital, treasurer of Ksoga State Conference in 2018, and past secretary of Bagalkot Obstetrics Gynec Society. We welcome you, sir.
Thank you, madam.
Welcome, Dr. Manohar.
We have other panelist, Dr. Uday Shri Urkara, and she is associate professor of Department of OBG in Hubli, and she is the secretary of Hubli Dharwad Obstetrics Gynec Society for 25-26, IMA FAP Dharwad Society, and she has many awards on her name and many publications at national and international journals. Her area of interest is high risk obstetrics, gynec endoscopy, and urogynecology. I welcome you, Dr. Vidyashri.
Thank you. Thank you, madam.
Welcome, Dr. Udayshri.
Thank you, madam.
We have two more panelists with her, Dr. Shweta Patil, who is Secretary of Belgaum OBGY Society, and Dr. Shweta, who is the Secretary of Mandya Society. We welcome both of you, Dr. Shweta and Shweta.
Welcome all the panelists.
We have Dr. Salma Afrin, Associate Professor of
BMCRC Bellary, and we have with us Dr. Divakar, consultant Divakar's Healthcare Davangere. We welcome you, Doctor. Ma'am, over to you, ma'am. Dr. Sneha, ma'am.
Yeah,
Sneha, ma'am is the
good evening.
coordinator for today's panel.
Yeah, very good evening to all of you, and I welcome all the panelists here today. We have heard very interesting talk, especially about the strategies in reducing maternal mortality, and of course, the environment and its effect on the women's health. Now we come to the fetal environment, and yes, our very essence of our these programs or the working of this committee is not only to reduce the maternal morbidity and mortality, but also to reduce the perinatal morbidity and mortality. So quickly, we go ahead with the panel discussion, which will be, of course, a very practical case-based discussion. So I welcome all the panelists once again. So friends, amniotic fluid, all of you know that it is the fluid that surrounds the baby. And why is it called as the sea of life? That it not only provides nutrition to the fetus, but also protects the fetus by the external heat, stroke, and acts as a cushion or shock absorbent for the fetus. It also protects the umbilical cord, which in turn is responsible for the circulation, baby circulation. And this is the one, it is also responsible for the development of the hearing and also the strong bond of this fetus with the parents, because the what we called it as this white noise, that is the sound which is of low frequency, the soothing sound of low frequency, which helps in developing the hearing of the fetus. And this amniotic fluid, definitely it has, it transmits the warmth of the mother directly. So initially it just constitutes about, before 12 weeks, it is only water and electrolytes, but after 12 weeks, it is carbohydrates, proteins, lipids, phospholipids, and urea. And all of you are very well versed with what is the normal amniotic fluid index and what is oligohydramnios and what is polyhydramnios and what are its effects and how do you practically manage it. So without much ado, we will straightway go to the case discussion. And here we have a very simple case for you, Dr. Manohar Tangsali, and all of us, let's discuss together. So you have this primary gravida with 2 months pregnancy. And, she is at present asymptomatic. She just comes to you because urine pregnancy test is positive, and she comes to you for routine antenatal care. When you do her ultrasound, you find that, yes, there is an intrauterine pregnancy of 8 weeks, but the sac size is small and the fluid inside is less. So what are the likely causes for this, and how would you counsel and go ahead with the management of this pregnancy? Dr. Manohar.
Okay, man. Good evening, madam. Good evening, everybody. Thank you for giving me opportunity to be a panelist in this meeting. Am I audible, madam? Hello.
Yes. You are audible.
Yes, fine.
Yes,
as you all know, the fluid is what is essential for life, and only Earth is having the water. We search other planets, there is no water. So water is there, fluid is there, then life is there. So as you know, in this case, it's primary 2 months. So the moment you see the small, like a small sac, it is alarming definitely. But only thing is we have to reconfirm whether we have taken the proper measurement or not. Whether sac is properly seen. Sometimes there may be little bit skill mistakes. And second thing is small history, asking whether there was little bit watery discharge or little bit bloody discharge, maybe threatened. Or after learning that, then really it is a small sac. We should be worried. Then we start thinking of the causes. As you all know, the likely causes will be usually the small sac. The genetic cause can be there. Uterine cause can be there. There may be some endocrinological problems can be there. And as we go ahead, there may be in the future this pregnancy can have medical problems like gestation diabetes or hypertension, preeclampsia, and some small some problems can be solved. Some are inevitable, like genetic problems. So the other commonly seen causes can be dehydration, diabetes we may be missing, So in future, she can go into preeclampsia. The baby may suffer with hypoxia. The more alarming is the chromosomal aberrations and the congenital malformations. We have to keep in track. Then we would like to investigate in such cases, basic investigations along with little bit viral markers. Along with that, we try to screen for the gestation diabetes or diabetes per se, and the baseline routine ultrasound, keeping the Doppler intact, and follow up the cases every 2 weekly or 3 weekly. And once it reaches the NT scan level, that time make sure that the dual markers are done, or possibly rule out the genetic causes, microarrays also, and try to screen for the preeclampsia with MAB and alternative Doppler starting from 11 weeks, and put them on EchoSpring 150 mg, and try to screen for routine endocrine problems also along with that after relating the chromosome problem.
Yes.
This is how I like to see the small sac pregnancies.
Yeah. So I'm sure I'm very happy that you have discussed all the possibilities, possible causes and the investigation. But the moment you see such picture, are you counseling your patient and the family? Because, this is a case, if at all, suppose next time you find that, all of a sudden it comes as a blighted ovum, or maybe sudden you find that the fetal pole is present, but cardiac activity is absent. So at this point of time, would you like to counsel this patient or the family?
Definitely, madam. We have to counseling them that she is not a straightforward case. She is high risk pregnancy. We should counseling them and keep them track. And if we are seeing CRL and good heart rate, and major genetic problems are ruled out a little bit. But as long as we go till NT, we cannot rule out, except like once you cross the NT and all, then we will be left with small chromosomal markers, trisomies and all. Other major chromosomes are solved, usually ruled out. We have to keep them counseled, ma'am, definitely.
Ma'am, can I add one point? Actually, when we see anything in fetal medicine, there is a dictum that which is quantifiable should be quantified. So, in such case, we can measure the mean sac diameter and CRL. If the difference between two is less than 5, then we call this as an embryonic oligohydramnios.
Perfect.
Okay, I repeat, mean sac diameter minus CRL. If it is less than 5, we can document this as an embryonic oligohydramnios, and we can counsel our patients, ma'am. Thank you.
So that's a very good input from your side, Megha. And yes, definitely, as you said, Dr. Manohar, possibility of spontaneous abortion, possibility of chromosomal aberrations, possibility of congenital malformation, and maybe if at all, all these are negotiated, possibility of fetal growth restriction and poor pregnancy outcome can be, expected. But then see, if at all you have a picture initially like this, what we said, small gestational sac and oligoamniotic sac, if suppose you do a follow-up and without counseling, if at all you get a picture like this, the patient and the relatives can blame you at the very next visit. And that is why the role of counseling is very, very important. Of course, rest everything we have discussed well. So thank you, Dr. Manohar, for discussing this case very well. We can go on to the second case now, Dr. Shweta Patil. We have this. Do we have Dr. Shweta? Dr. Shweta? I don't think.
She's
do we
present.
have, yeah? Is she there?
She's not seen, ma'am. The one who is there can, other panelists can take up this call.
Yeah, so do we have Dr. Divakar? Yes, we can go ahead with Dr. Divakar. Please try unmute. Yes, yes. Hi, Dr. Divakar. We have this primary gravida with 4 months amenorrhea, and she is, she has no complaint, but she has just come to you for routine antenatal checkup. And when you examine, you find the vitals are normal, blood pressure is normal, uterine size is little less than what is expected at that particular gestational age. Our ultrasound report says gestational age is 16 weeks, placenta is anterior, liquor severely less, internal os is close. So how do you tackle this patient? What investigations you would like to go ahead, and how do you manage this?
Yeah, this being very early gestation, actually we have to think of first main thing, we have to think of placental insufficiency or any chromosomal thing. Very early onset this thing, there is a chance of chromosomal thing. So first we have to rule out that. So you have to do a detailed scan and check for any, is she having any like a signs of any chromosomal abnormality. Then if such things are there, then you can go ahead with either the NIPT or definitive test, like you can go for amniocentesis and rule out any.
Right. Before that, would you like to
Yeah, you
for
want to,
any,
otherwise any PPRM, yeah, is she having any, like, history you have to take regarding
Yes.
leaking
Yes.
or something like that.
Yes. Yes.
So is she having
Perfect.
any PPRM, anything? So that like by speculum examination or by giving this thing, like pad for observation, that also can be ruled out on this.
Yes.
Yeah.
Yes.
Okay.
So whether the fluid was normally present there and it has leaked out, that's the first possibility. Then,
Yes,
of
ma'am.
course, next comes the placental insufficiency where you have the oligohydramnios.
Yes, ma'am.
But definitely the congenital malformations where
Yes.
you can have these oligohydramnios, like
Yeah.
renal agenesis or
Yes,
bilateral
ma'am.
non-functioning kidneys, like
Yes, yeah.
multiple dysplastic kidneys, and
Yes, ma'am.
the uropathy, genetic and chromosomal aberrations, as we have said, certain vital markers. Even
Yes.
simple hyperpyrexia if the patient faces because of any reason, she may land up into acute oligohydramnios. Right?
Yes, ma'am.
So how do you evaluate and how do you go ahead with the management?
Yeah. So first of all, you have to rule out the basic non-pathological one, wherein like PPRM you have to rule out, no, by speculum, as I said, like speculum examination or PAT for observation you have to do, and then like detailed anomaly scan has to be done to rule out any renal, like you said, like renal agenesis or any other chromosomal abnormality, like scan findings of chromosomal abnormalities, man. And other things like any early onset of PIH is very rarely, ma'am, like because, sorry, 1 second. Yeah. That is the main thing, ma'am, actually. And other, if you are suspecting PPRM, you have to detail the investigation for any infection markers like CRP, and then
Right.
CBC you have to do. And
Yeah,
then,
and
yes,
of course, when you suspect chronic hypertension, which is
yeah,
superimposed or pregnancy aggravated
yeah,
hypertension, or
because since
maybe
he's only 16, I was thinking, yes, ma'am, okay, yeah.
and pre-existing diabetes, with vasculopathy, etc., you may have to go ahead with all these investigations and predictors of pH and all this, biophysical
Yeah.
as well as biochemical markers. Anybody wants to add anything here, Dr. Sudha? Then how do you go ahead with the management? All of us have discussed about the leaking and all the investigations to rule out the congenital malformations, the chromosomal aberrations also, and of course the medical diseases, medical comorbidities we have talked about. Now, how do you go ahead with the management of?
Yeah, management per se, like if we are, if the leaking is confirmed, then we can actually we can just put her on antibiotic, and then we can do conservative management also, madam. Actually, if there is no infection or CRP, say it's not CRP is not raised, we can definitely continue till 30 to 34 weeks also. If there is no other, sometimes like it might seal off. If it is a high leak, sometimes it can seal off, and then pregnancy can be continued, ma'am.
Okay, from 16 weeks onwards.
Yes, ma'am, sometimes.
Okay. Any difference of opinion here?
Ma'am, I want to share one thing. Actually, I had got a patient of 14 weeks. She had, I did circlage and she had leak. So then Soumya Dinesh ma'am is there, infertility specialist in Mysore. She did the fresh frozen plasma and fresh frozen fibrin. For that, AFI of 2 centimeter is required.
Yeah.
So she had that and she did it, and it closed actually. She is now 30 weeks period of gestation.
Right.
She's doing well.
Yes. So
that
exactly,
if
that
AFI is there, then we can try that.
Yes, so definitely I would also like to share with you that the sealing of this membrane leakage is definitely possible, and if at all, at subsequent visits or maybe subsequent ultrasound, you find that the amniotic fluid is adequate and there is no compromise with the fetal circulation, definitely such pregnancies can continue ahead. And we also have patients who have continued for 4 or 5 months, ahead. So that is what is the message. So otherwise, routinely, if at all the patient gets a rupture of membranes, within 24 to 48 hours, the contraction sets in and the pregnancy is expelled out, right? But if there are no contractions and things go fine, we can conservatively manage this pregnancy and can take to salvageability, right? So that is what is the message. But then you have to really monitor this patient, the mother as well as the baby, very stringently. The mother, of course, has to be monitored and evaluated for not only for the medical disorders, but for the infections what she is likely to have. So every weekly, so basically daily, yes. Anybody wants to add, how do you monitor such mother when she has the premature rupture of membranes or leaking? Yes, Dr. Shweta, can you add? Yeah.
Yes. In the beginning, we did
Because now
CBC.
you have monitored, you have managed this case, so you are the best person to talk about this. So what all things you have evaluated from mother's side and
first we did cervical vaginal swab for culture sensitivity to look for any infection, and prophylactic antibiotic was started. Actually, she was started on zone ceftriaxone 1 gram BD. Then she underwent her blood count, CBC, CRP. So it was normal at the procedure time. And after that, after 48 hours, this was repeated. And weekly investigation, CBC, CRP, and culture was repeated. And betadine, high vaginal swab. And betadine pessaries was given and candid pessaries alternate day. So it was their protocol, just we followed that. After like 24 weeks, now we are like doing culture once in 3 weeks, ma'am. Then CBC, CRP once in 3 weeks, and scan once in 15 days. So the last scan was normal. Baby weight was 1.3 kg and AFI was around 16.
Yes.
So
So for maternal evaluation, mainly for sepsis, and of course the medical disorders, whatever you have to evaluate as a routine as well, you know, so whether you would like to go for 24 to 28 weeks, the OGCT once again, you know, whatever routine investigation you are doing for the pregnancy, for the mother, that will continue. In addition, you have to evaluate her for the sepsis profile you have to go for. And for the fetus, the growth clinically, fetal movements and fetal heart sound, and on ultrasound also, the Doppler ultrasound, you have to do it quite frequently, maybe every fortnightly, as you said, rightly. So now, how will you monitor this pregnancy, and when do you deliver this patient? I would ask you only once again, now that your patient is 34 weeks, Dr. Shweta, how would you like to deliver her, and when would you like to deliver her?
Mom, steroid prophylaxis has to be given around 28 weeks. So any like sepsis or any culture positive, then we are planning. Otherwise, we are planning around 36 to 37 weeks, ma'am. If everything is good, fetal circulation, Dopplers are good, IFI is good, and mother is stable, no like signs of infections, and we can like push up to 36 weeks.
Yes. So anytime you have, your aim is of course 37 weeks. But if at all there are any problems, your aim will be little lower, that is 34 weeks. But before that, you would like to prepare your fetus with magnesium sulfate for neuroprotection and the steroids for lung maturity. I think that should be a good plan. So we have already ruled out the major congenital anomalies, and we have taken care of all this leaking and the medical disorders. Dr. Sudha, any comment from your side? Dr. Sudha? She was here just now. Okay, we'll have her.
Madam, can I add something, madam?
Yeah, please.
Madam, we should ask the history of medications also sometimes.
Yes.
Like AC inhibitors and all, or if unknowingly they are taking antihypertensives and all, sometimes they can cause oligohydrums also.
And even painkillers.
Yes, analgesics
Painkillers
also.
also.
Right.
Yes.
Yeah,
Yes.
that I just talked to you, when any kind of hyperpyrexia also can lead to oligohydramnios that we talked about. So in that, some higher antibiotics, the pyrexia per se, and even the analgesics antipyretics can lead to. And other medications, yes, definitely, because ACE inhibitors are the ones which are strictly prohibited or contraindicated during pregnancy. So definitely we have to keep a watch on it. So we go ahead with the third case now, and I think this is a case for you, Dr. Shweta. But then we can have somebody else.
Udayshri.
Yeah, Dr. Udayshri. So we go ahead with you. This is second gravida, para 1, 34 weeks pregnancy. And she comes to you with pain in abdomen and difficulty in breathing. The fetal movements are less. She's got little tachycardia, pulse rate 100, blood pressure is normal, mild pallor, mild pedal edema. Uterus is over distended, tense. Fetal parts are not well palpated. Fetal heart is 140 per minute regular. There is no definite uterine contractions observed in 10 minutes. When you do her internal examination, ossis spatulus 1 centimeter, tense bag of membranes, no show, presenting part is high up. Now her AFI on ultrasound is 22. Apparently there are no anomalies. Okay, so what is your diagnosis? What are the problems associated? How will you counsel the patient and the family? And how would you like to go ahead with the management?
Ma'am, diagnosis is acute respiratory embarrassment due to acute polyhydramnios.
Okay.
So she's 34 weeks and sudden increase in amniotic fluid. Though ultrasound is showing AFI of 22, there is sudden increase. Even AFI of 22 also can cause respiratory embarrassment.
Yes.
And PV finding, though ossis spatula, she's a second gravida, which can explain the patches, but it is, and also short cervix, 1 centimeter. So
1 centimeter is the dilatation.
sorry, ma'am. Yeah, 1 centimeter. That's why BOM could be diagnosed. Yes, ma'am. So we'll have to actually, it is like both. So diagnosis and management will have to happen parallelly because she's coming with an acute respiratory embarrassment.
Right.
So we'll do an ultrasound and find out how much is the FI and also the cause if we are able to find out. Usually acute embarrassment will be due to some fetal problems.
Okay.
It can be salt losing nephropathies like Bartter syndrome or esophageal atresia, duodenal atresia, where it can cause such increase in amniotic fluid.
Even the open neural tube defects.
Yes, open neural tube defects also, ma'am. And sometimes severe fetal anemia also can cause that. And my maternal management will be for acute management, we'll have to do amniocentesis, madam, amnio reduction rather.
Polyhydramnios, would you like to go ahead for some investigations which may not be done by this time? So
yes, madam. We should always keep in mind diabetes. So we'll have to rule out abnormal sugars, screen for infections, genetic abnormalities of the fetus. Also keep isoimmunization in mind. So recheck if there's a possibility of fetal anemia due to isoimmunization, be it Rh negative or rare blood groups. And sometimes fetal karyotype may be done when we get sample from amniocentesis. We can send it for karyotyping also if we're suspecting fetal genetic problems or chromosomal problems.
Yes, yes. Certain types of hydrops may be because of the viral infections, as you said, the Rh negative isoimmunized pregnancy and even the non-immune hydrops.
That is, all the causes for non-immune hydrops will have to be also ruled out.
Yes. Okay. Go ahead. So this patient is definitely, she's prone for preterm labor, right? So
yes,
what will be your concern and how will you take this pregnancy ahead? She's
now because she's 34 weeks, madam, it is preterm. Actually, it is between early preterm and late preterm rather. So we have to buy time at least for steroid prophylaxis and neuroprotection by magnesium sulfate. And because she's having acute respiratory embarrassment.
What is the ideal period for magnesium sulfate?
Ideally 32 weeks and below, madam. Early preterm deliveries, magnesium sulfate protection is
that
ideal.
is why I asked you this question, because IAP very specifically says, IAP and NICE guidelines, 32 6 days at the most. But definitely we Indians are following, 34 weeks. Because some people are saying that, about steroids also, we say before 34 weeks. But
34 weeks, yes, because late complications of steroids are a concern.
Yes. Okay, go ahead.
And regarding magnesium sulfate, madam, the dose is loading dose as we give for our imminent eclampsia patient, 4 grams loading dose followed by 1 gram per hour.
Yes.
So idea is that when the baby is delivering, magnesium level should be there in the neonate. It protects it from the cerebral palsy, intraventricular hemorrhage, and the morbidity due to this.
Yes.
So if we think delivery may occur within 4 hours of starting magnesium sulfate, it may not be useful. But if we are able to prolong the pregnancy beyond 24 hours, there is no need to continue the magnesium sulfate. And there are also no guidelines to give a repeat dose of magnesium sulfate if she goes into labor later, madam. So this is about Maxel. And pardon?
Steroids.
Steroids, yes, madam. We can choose dexamethasone versus betamethasone. I will not go into the controversies. Both are being used. So 24 grams in 24 hours. If it's betamethasone, 2 doses, 12 grams, madam. And it's 6 grams of dexamethasone, 4 doses.
Yes. So for this,
Idea is 48 hours time we should be able to buy.
Yes, yes. Foxy and IAP has a joint statement saying whether it is dexamethasone or betamethasone, irrespective of the dosage and regime, 24 milligram over 24 hours. That should be, given to the patient, and we should at least have 48 to 72 hours so that, we get the desired effect.
Yes, only thing is because it's a case of polyhydramnios, we should rule out few contraindications for steroid therapy if they are present. So rule out abnormal sugars, risk of infection in her.
Yeah,
and
but
high sugars can be managed with insulin also.
Yes, that is what I'm saying. Even if she has diabetes, there should be no hesitancy in giving, because routinely we all are giving this, okay?
Yes,
Only
madam.
it tells you that you have to be little cautious as far as the sugar levels are concerned. The control may get disturbed, and you may have to hospitalize this patient or monitor her sugars for 48
sugars and give insulin on sliding scale till the window period is
perfect. Now, how do you, so what is your aim to deliver? What is the exact timing?
Madam, now parallelly I told diagnosis also is important. In spite of this management of steroids and magnesium sulfate, if she goes into labor, idea will be to allow her to go into labor, but be careful to avoid sudden decompression of the uterus. So do a controlled ARM, or even transabdominal amniocentesis in the early labor also can be done, because such huge fluid can cause sudden decompression, madam.
Yes. In fact, I would suggest that when you have this is a patient where you can have malpresentations and malpositions. So here you should try and avoid the ARN as far as possible, as long as the patient, goes into
is in active labor and is about to rupture membrane.
It gets
And
yes.
And ideal will be to have an ultrasound, keep repeating for the presentation, madam, once she goes into active labor also, because there can be unstable lie because of lots of liquor. Even if cervical dilatation has occurred, head may not get fixed.
Yes, that is why if at all the head is fixed, you can go ahead. Otherwise, what is called as controlled ARM that you have
ARM.
Yes.
Better use spinal needle, madam. Make a small puncture, allow controlled escape of the fluid, and then.
Okay, so how to manage, after this 34 weeks, as you have already talked about the magnesium sulfate steroids, and let the patient go into spontaneous labor on her own. Maybe you try to preserve the membranes till the late.
And also important is to see that we are having the pediatrician neonatologist ready to receive the baby. Yes, this baby will require help.
Yeah.
And better deliver in a tertiary care center with ICU facility, madam, an ICU facility.
Right. So, Dr. Salma, what will be the prenatal therapy for this? Dr. Salma? Please unmute yourself. Please unmute yourself.
Yeah, good evening, ma'am.
Good evening.
Ma'am, am I audible?
Yes, yes, definitely.
Yeah, as it is polyhydramnios, and polyhydramnios usually they start manifesting early in just late second trimester, that is by 24 to 26 weeks. So that time itself, first we should find out what might be the probable cause for polyhydramnios. It can be either maternal cause or it can be the fetal causes. Those maternal causes, particularly it is the uncontrolled gestational diabetes. In these uncontrolled gestational diabetes patients, we should think of getting a good glycemic control. This glycemic control we can approach either with a good proper diet initially for 2 weeks. If not possible with that, then we can go for an insulin therapy also, along with our OHAs are available. other causes to be ruled out, particularly the immune and non-immune hydrops, for which we have to do a particular detection of the antigens and the antibodies in the blood, which will help us to identify the type of hydrops fetalis. If it is due to any cardiac anomalies or any arrhythmias present and hydrops has been identified as the cause of polyhydramnios, then we can give certain medications or any beta blockers like digoxin can be given to reduce tachyarrhythmias or the arrhythmias can be reduced, and surely we can try to reduce the polyhydramnios to some extent.
Yes, and the isoimmunization, the isoimmunized fetus or the sensitized fetus.
Yes, ma'am.
With severe anemia, you can go ahead with intrauterine therapy or intrauterine transfusion.
Yes.
Right?
Yes, ma'am.
That is how we will try to pull on the pregnancy till salvageability.
Yes,
so,
yes.
Thank you, Dr. Salma, and of
Thank you, ma'am. Thank you,
course, for discussing these cases so well. Rest of the obstetric management, all of you know well, so I'm not going to discuss. Today, our purpose is only to discuss the fetal environment. So, Dr. Divakar, once again, we come to you. This is a third gravida para 2 with previous 2 normal deliveries. The patient comes to you in 9 months amenorrhea. She complains of leaking since 1 to 2 days without labor pain, with labor pains since yesterday. Pulse rate is 110. She's afebrile at present, but she has dry tongue and blood pressure is 110/70. No pallor, no pedaledema at present. Uterus is full term. She's got good contractions, 35 to 40 seconds every 3 minutes. Head is fixed and fetal heart is 120. Even the cervix is 6 centimeter dilated, 75% effaced, membranes are absent, like a thickly meconium stained. Station is -2, pelvis adequate. How would you go ahead with the management of this patient? Dr. Divakar. Dr. Manohar, you can take up this case.
Yes. As you know, madam, this history tells us she has leaked PV since 2 days, more than 12 hours definitely. She's high risk for like the fetus is inside is also high risk, and she is already dehydrated and liver since long time, I feel.
Yes.
So such patient has to be kept in the labor room and strictly monitored for the continuous fetal monitoring, and if possible, try to deliver them within few hours under the observation. If adequate pelvis is noted and she is easily allowable for vaginal delivery, keeping the neonatologist next to you. And if at all any tachycardia is continuing and there is a fetal distress noted, confirmed by the scalp pH, and make sure that it is confirmed fetal distress, and go ahead with the cesarean or immediate delivery with vacuum or
I would interrupt you here little because there is the patient has had leak, right? So she doesn't have amniotic fluid now coming down. So she is having thick meconium stained liquor because the quantity is less. The fetal heart is 120. If she is progressing well, would you like to deliver her vaginally or would you like to take her straightway for cesarean section?
Under observation, I would like to give a trial, madam. 1 to 3 hours, because she is multi. So definitely progress very nicely and keep her hydrated, because right now the uterus is exhausted. Give a good Phillips replacement and give them oxygen and keep the baby, avoid hypoxia in the baby and acidemia in the baby, and give them ringal lactate and oxygen to the mother. Keep left lateral. Definitely, we may achieve 50 to 60% vaginal deliveries.
Okay.
If at all it is not going well, then go ahead with the emergencies.
Okay, so already you have discussed that. Yes, definitely she has had 2 normal vaginal deliveries, and already she has progressed so well up to 6 centimeter at least she has come. So maybe in another hour or so she will deliver vaginally. But definitely, if at all she is landed up into hypoxia and all these complications, whether you would like to, because she has no liquor, so would you like to go ahead with amnio infusion? Do you have any experience in this?
Right now it is guarded risk, madam, because he has PRM since more than 24 hours.
Right.
And indulging infection is more riskier.
Yeah.
But under good antibiotic coverage, we can give a trial of amniocentesis, and it can we can avoid cesarean section. To prevent the cord compression, we can give amniocentesis. We can give infusion.
Right. Right. And you have very correctly, aptly mentioned about the continuous electronic fetal monitoring, because this is a very high risk patient. Variable deceleration because of cord compression is always will be there. But then if at all you have late decelerations, you should be able to pick up at the earliest, and you should, cut short the labor, or maybe you have to take her up for cesarean section at the earliest. Okay. So I think we don't have Dr. Shweta Patil, so we would just like to have your opinion on this, Dr. Shweta, and then we conclude the panel. Okay, this will be the last case for us. Do we have Dr. Shweta joined, our expert? We could see her, but she's not here, I suppose. So we just go ahead with the last case now. So we have this registered primary gravida with full-term pregnancy, normotensive, non-anemic, and she comes to you in latent labor. So she started having strong uterine contraction after 12 hours of admission. ARM was done and the labor was augmented when she was 3 centimeter, fully effaced, and Liker was clear. So within few minutes, she started getting very strong contractions. Suddenly she becomes restless and breathless, thirsty. Pulse and BP was not recordable. What are the differential diagnoses and how do you manage, Dr. Shweta?
Mom, it seems like amniotic fluid embolism is the first diagnosis, because after ARM she became very restless, and so her pulse and BP are not recordable.
Right.
So for amniotic fluid embolism, main thing is supportive therapy, ma'am. Airway, breathing, circulation, those things needs to be maintained, and team effort should be there. And we should give supportive therapy and look for. And after ARM, like abruption also be ruled out, because after ARM, like there may be concealed abrasion sometimes. So hypovolemia and those things to be looked into.
Abruption will happen only when there is sudden decompression, right? So here the fetal head was fixed well and she was having good contraction. So possibility is less likely, but amniotic fluid embolism per se is a diagnosis of exclusion, right? So it is just a catastrophe she has presented with. So this can be thromboembolism, or unexplained shock, hypoxia, hypothermia, even blood transfusion reaction, or even drugs hypersensitivity, right? So you have to rule out everything. Then we come to the diagnosis of amniotic fluid embolism. How do you manage this? Dr. Shweta, how do you manage this?
First thing is supportive therapy. Then we should look for other any like drugs or any induced like any complications other than that. So team support should be there. I already told airway, breathing, circulation and all has to be like maintained, and multidisciplinary approach has to be maintained. So then.
Obstetrician, anesthetist, intensivist, pathologist, hematologist, blood bank, everybody together, right? Okay. So once, what would you talk about the amniotic? What one message you want to give? What is the exact, diagnostic sign of amniotic fluid, I would say, or diagnostic feature of amniotic fluid? Amniotic fluid embolism.
It is a diagnosis of exclusion, and we should be very cautious and be prepared.
Right. And how do you actually confirm it 100%? How do you actually confirm it 100%? Dr. Manohar?
Yes, madam.
How do you confirm it 100%, the amniotic fluid embolism?
As it is told, like a rule after excluding everything, madam, as blood transfusion and all, but confirmation will be only by histopathology.
Perfect. So because it's a postmortem diagnosis, because you have to confirm the presence of amniotic fluid in the alveoli, then only you can label it as it is. But then the clinical picture, sudden catastrophic presentation, when you rule out all the other causes of, sudden catastrophe, as we have already said. So friends, we just conclude this panel because we just, we have, just the fetal environment, the amniotic fluid, how it is truly the sea of life. That is what we have discussed. That initially the amniotic fluid is clear and up to 12 weeks it's only water and electrolytes. Later on it has, it becomes cloudy, little hazy, the fetal hair, vernix caseosa, the material released from fetal lungs, everything is there. The fetus inhales and exhales inside the mother's womb. It also, it swallows the amniotic fluid, and because of the inability to swallow the amniotic fluid, it can also lead to polyhydramnios. You have lots and lots of maternal condition and fetal condition that can lead to polyhydramnios, and definitely we have all discussed the conditions, how to evaluate as well as how to go ahead with the management. So with this, I thank all of you, and I would just like to give this message that work for a cause, not for applause, and live life to express, not to impress. Don't strive to make your presence noticed, just make your absence felt. So with this, I would like to just make a humble appeal to all of you that I'm contesting for Foxy Vice President from West Zone, and I look forward to have your wholehearted support and your votes from all of your society members. So I request once again to everybody, I thank the entire team Ksoga for having me here, and of course, I thank all the esteemed panelists for their great inputs. Thank you so much once
Thank you,
again.
madam. Thank you, everybody. Thank you so much.
Thank you, madam. Thank you for the opportunity. All the best, madam.
Yes, thank you. I can see Madam Ashalata Malapur. Madam, anything from your side? You can unmute yourself.
We can have
Yes, it was a really wonderful program, madam, and especially environmental effects were very good, and even maternal mortality and the panel discussion also very nice.
Thank you.
So
Thank you so much.
much.
Thank you so much. This was a little different subject, but then we had to discuss it on the environmental day, so we have chosen this topic. Thank you so much. Over to you, Megha.
Yeah, Dr. Aparna, I would request you to express your vote of thanks.
Yeah, thank you. That was an excellent and exhaustive panel discussion, ma'am. Thank you, everyone. Now I conclude the webinar by thanking our moderator, Dr. Sneha Bhuyar, ma'am, for a wonderful academic feast and for letting me be a part of it. I sincerely thank our esteemed chief guest for constant support for the webinar, and the chairpersons for chairing the sessions and throwing that light on the topics, and the speakers for the dedicated, detailed lecture, and the panelists for the most enthusiastic participation. Lastly, I thank the wonderful delegates for attending this webinar and making it a successful one, and looking forward to engaging in more such discussions. And thank you, Shield and Stalin, for this event. It's been a constellation of great minds pouring out their ideas and practical points, which will definitely help us for better management of patients. Thank you so much. Ma'am, I would just want to say hello to Dr. Shobha Dhananjay, madam.
Yes,
She is
yes,
my
yes.
UG teacher.
Oh, nice. Very
Madam,
nice.
namaste, madam.
Yeah, namaste.
I was your
Thank you, Madam
undergraduate
Shobha.
student.
Can we have, we can have some
Yes,
expert
ma'am.
from your side.
Very nice panel discussion, madam. Amniotic fluid has been explained from first trimester to last trimester for the fetus as sea of life. Definitely it has thrown light on that. And all the panelists have been excellently prepared and deliberated themselves about the amniotic fluid. And what we learned is sealing of amniotic fluid from fresh frozen plasma. Dr. Shweta has explained. Definitely, I have not come across this type of cases in the first trimester and continue the pregnancy till third trimester. It's a wonderful. Definitely, I totally enjoyed from first to last. Thank you so much for the opportunity given, Dr. Sneha ma'am. And I wish all the best for your vice president post. Definitely, good luck.
Thank you, madam.
Thank you, Dr. Aparna, for
I
being
will
here.
personally
Excellent
thank
episode.
Dr. Barkol and Dr. Udayshri from Hubli, President and Secretary. I would personally thank the team Belgavi and Ballari and Hubli Dharwad, I have already said, and Mandya. I would like to thank everybody from the bottom of my heart. Thank you so much.
Thank you, ma'am. We should thank
Thank you,
Aparna for
madam.
being an excellent MOC. Thank you, Aparna, for accepting
Thank
our
you, thank you.
invitation.
Greater thanks to
Thank you,
Sneha
madam,
and Dr.
and thank
Megha
you
for
for
this
giving us
opportunity.
opportunity.
Thank you.
Thank you so much. Thank you so much.
Thank you. Good night, everyone. Thank you.
Good night.
Good night. Thank you.
Good night.
Good night. Good night.
Good night.